Welcome to our conference session titled Transplantation for MDS, Aplastic Anemia, and PNH. Thank you for joining us. My name is Lee Clark, Director of Patient Services, and I'll be moderating the presentation today. As we get started, I'd like to recognize the generous support of our corporate sponsors and the generous support of our patients, families, and caregivers for supporting the conference today. Immediately following the presentation, there will be a question and answer session. If you're participating online, please feel free to submit your questions at any time during the presentation using the Q&A icon in the engagement panel on your right. To submit a question or comment, type your question in the Q&A text box window, and when you have finished typing, just hit enter. We'll do our best to get to everyone's questions today. When asking questions, I do ask that you do two things to help me manage the incoming questions. First, submit your entire question all at the same time. Second, please do not share private health information in your question. Our expert speaker cannot answer any specific questions related to your personal health care. Our expert today is Dr. Antonio Jimenez Jimenez, and he is an assistant professor and an attending physician at the University of Miami Sylvester Comprehensive Cancer Institute. His area of expertise is in clinical research using hematic stem cell transplantation and cellular therapy for the management of high-risk acute myeloid leukemias, including myelodysplastic syndromes, myeloproliferative neoplasms. He is also interested in assessing genetic factors that predict post-transplant relapse and strategies to manage and minimize the management of this complication. It's my extreme pleasure to welcome Dr. Jimenez Jimenez.
Thank you so much for that kind introduction, Lee. I want to thank the Aplastic Anemia and MDS International Society for this invitation. And of course, I want to thank everyone for being connected and present in this meeting. I'll be discussing some updates in transplantation for MDS, aplastic anemia, and PNH, and some of the bone marrow failure syndromes. Next slide, please. Next slide, please.
Dr. Jimenez, they're working on it. They'll be right with you.
Okay, wonderful. Thank you.
Dr. Jimenez, we're ready to go. Thank you for your patience.
Wonderful. No, not a problem. Next slide, please. These are some of my disclosures and conflicts of interest, and I will be discussing the use of an off-label and investigational product during my talk. Next slide. Next slide, please.
Dr. Jimenez, they're working on an issue with the PowerPoint. Just a second.
Not a problem. Okay. Can you hear me now?
Yes, go right ahead. Thank you.
Wonderful. Some of the topics I hope we'll get to cover today. First, I want to go through some of the basics of transplantation. It's a complex process, and sometimes it's very useful to go through just some of the basic notions of what transplant is. So I'll be discussing what is a hematopoietic cell transplant, types of transplant, discuss briefly some of the complications and side effects following transplantation, and then go more in detail in the specifics of transplantation for MDS and some of the bone marrow failure syndrome, and talk a little bit about the indications and the available data to date. Next slide. So what is a hematopoietic cell transplant? Hematopoietic stem cells are progenitor cells that are produced in the bone marrow, and they have the ability to become any kind of blood cells the body needs. These progenitor cells are constantly dividing and maturing into different type of blood cells with the purpose of replacing older and worn out blood cells in the body. Hematopoietic cell transplant or bone marrow transplant or stem cell transplant, and this change can be used interchangeably, is a procedure in which the patient receives healthy stem cells to replace diseased or damaged stem cells. And very broadly speaking, we have two types of transplant. Autologous transplantation, where we use the patient's own stem cells, and allogenic transplant, when we use stem cells from a donor. Next slide, please. In autologous transplantation, essentially we again use the patient's own stem cells. This is a illustration of what an autologous transplant looks like. And essentially the first step is make sure we are able to collect enough stem cells. We put the patient through a process called mobilization, in which we give growth factors and other medications to increase the number of stem cells produced by the marrow. Once we reach a sufficient number, then these cells can be collected through a special machine called an apheresis machine. These cells are collected from the peripheral blood, and they can later be stored and processed for later use. We then follow this with cryopreservation, or we freeze these cells, again, so the cells can be subsequently used, and then we admit the patient to the hospital. The next step, we give high doses of chemotherapy and sometimes radiation. We call this the conditioning regimen. And the purpose of this conditioning regimen is to prepare the body for the transplant and eliminate any residual disease. Once this is completed, the frozen stem cells are thawed and infused back into the patient. These stem cells travel into the bone marrow, and a few weeks after the transplant begin producing new blood cells, typically 2 to 4 weeks after the transplant. And right about this time, marrow is working properly, and most patients can be safely discharged home. Autologous transplant, it's a very useful treatment strategy for patients with multiple myeloma, most lymphomas, certain chronic leukemias, but it's not a therapy that is particularly useful in patients with MDS and bone marrow failure syndrome. So we won't not be elaborating much more about autologous transplantation today. Next slide, please. Allogenic transplant, on the other hand, involves the use of stem cells from a donor that can be related or not to the recipient. Next slide, please. This is what an allogenic transplant looks like. Once we identify a suitable donor, and we'll discuss briefly in a few slides what a suitable donor is, we also undergo the process of mobilization. Again, we give this donor growth factors and other medications to increase the number of stem cells so we can collect them on the peripheral blood. Alternatively, we can harvest the stem cells directly from the bone marrow, and these cells are later stored and processed for subsequent use. Cells can be used fresh, and most recently and now more popularly, we are choosing to cryopreserve these products and can be used at any time after the collection has been completed. The patient that intends to receive these cells then undergo conditioning treatment again, high doses of chemotherapy and sometimes radiation, with the purpose of eradicating any residual disease, creating the physical space on the marrow for the new cells to grow, and importantly, suppressing the immune system so the patient does not reject the cells. Once the conditioning has been completed, the cells are infused back into the patient through a catheter. And again, these cells travel to the bone marrow and begin to produce new blood cells a couple of weeks after the transplant has been completed. Allogenic transplant, it's a curative treatment strategy for many hematologic malignancies, including acute myeloid leukemia, MDS, and bone marrow failure syndromes. Next slide, please. Allogenic transplant is a particularly complex process, but two of the main ways in which transplant can help patients with bone marrow failure, MDS, and myeloid malignancies is, number one, the conditioning chemotherapy or the conditioning treatment, sometimes we give radiation, can eradicate any residual disease. But most importantly, when a patient receives a bone marrow, they also receive a new immune system. And this donor immune system has the ability to attack cancer cells or abnormal hematopoietic cells. And we call this the graft versus tumor effect. Next slide, please. In graft versus tumor effect, again, when we perform a transplant, patients receive a new bone marrow and new stem cells. They also receive a new immune system. And this donor immune system has the ability to identify any cancer cells or abnormal hematopoietic cells as foreign and attack them, allow them to patients to achieve deep remissions and eventually be cured. This graft versus tumor effect is critical for the effectiveness of allogenic transplant and can also prevent the disease from relapsing. That is, the disease coming back after the transplant has been completed. Next slide. This is an illustration of what the graft versus tumor effect looks like. You see here to the right, the orange cells are specialized white cells called T cells. These T cells from the donor have the ability to recognize antigens, which are special protein in the surface of the cancer cells. Here, we have an illustration of a leukemic blast. Once the donor T cells recognize these abnormal cells or malignant cells, they have the ability to recognize them as foreign and attack them, again, allowing the patient to achieve a remission and eventually be cured. Next slide, please. And while allogenic transplant can be curative for many hematologic malignancies, and for many patients is sometimes the only curative treatment strategy, transplantation is not for everyone. Some of the factors that determine whether a transplant is an option or not include the patient's disease, the risk of their disease, their age, but more important than their age, their ability to tolerate intensive treatment. Performance status and comorbid conditions are much better predictors of fitness to receive intensive therapy compared to age alone. Also, in order to do a transplant, we need a donor, so we need an available donor. And ultimately, like any medical intervention, the decision to proceed with transplant or not comes down to weighing the risk of the benefits and the patient's individual goals. Next slide, please. I always tell my patients to proceed with a transplant, we need three things. The patients need to be in good health. They don't need to be in perfect health, but need to be enough for the transplant. Number two, achieve some degree of disease, and how profound this control is really depend on the patient's disease, their age and fitness. And number three, we need a donor. The definition of an ideal donor is constantly evolving. In the transplant infancy, many years ago, the only option to proceed with transplantation was using an identical twin. And we have really moved past that initial requirement. But again, the standard of care continues to be identify a donor that is well matched with the recipient. When we're looking for donor matching, we do a special test called HLA matching. We all have different set of proteins or markers in the surface of most of our cells. And we call these group of proteins are human leukocyte antigens, or HLA. Think of your HLA as your immune fingerprint. It's unique to you, but it could look similar to other people. There are many HLA markers, but HLA typing in clinical practice is usually based on 8, 10, or 12 HLA markers. Next slide, please. And we inherit half of our HLA from our parents. Half of HLA comes from mom, half of our HLA comes from dad. So by definition, we are half match or haploidentical with our parents. Because of this pattern of inheritance, there's a 25% chance that we will be fully matched with each one of our siblings, and there's a 50% chance that we will be half matched with our siblings. We're also half matched with our kids because, again, of this pattern of inheritance of HLA. Next slide. But for patients that do not have matched sibling donors, we can look for unrelated donors in the National Marrow Donor Registry. This is a very large registry with close to 40 million potential donor volunteers. And nowadays, we can virtually identify a donor for every patient. Next slide, please. The likelihood of finding a fully matched donor, it's really dependent on the patient's race and ethnicity. For patients that are Caucasian, the likelihood of finding a fully matched donor, that is an 8 out of 8 HLA match, it's close to 80%. But if the patient is Hispanic or Latino, that number drops to less than 50%. And for an African American or Afro-Caribbean patient, less than 20%. Fortunately, we have the transplant and prevention of graft-versus-host disease has evolved enough that we can use partially matched donors, 7 out of 8, 6 out of 8, 5 out of 8, 4 out of 8, which means that we can potentially offer a transplant to every patient irrespective of their race and ethnicity. Next slide. For patients that do not have any available options in the registry, again, there's always the choice of using a half match within our family. Again, our parents and our kids are haploidentical, and there's a chance that our siblings might be too. And cord blood transplant is another strategy, much more popular in the pediatric transplant setting. Next slide. Prior to transplant, we need to prepare the body for transplant, and we call that treatment the conditioning regimen. The conditioning regimen purpose is, again, to eradicate any residual disease, to suppress the patient's immune system so they don't reject their donor cells, and also to create the physical space for the cells to grow. For most patients, if they're young and fit, we aim to give very high doses of chemotherapy and sometimes radiation, and we call this a myeloablative regimen. It works, again, by eradicating any residual disease and through this graft versus tumor effect of the donor cells. Again, the immune system attacking any residual disease. For many patients that are older or not fit enough or strong enough to undergo very high dose chemotherapy, now there's the option of do a lower dose transplant. We call this reduced intensity or non-myeloablative transplant. And that transplant allows us to transplant older patients or frail patients that will not be a candidate for transplant otherwise. The success of this transplant depends heavily on the graft versus tumor effect, or again, this immune attack of the donor cells on the disease. Next slide, please. Transplant is an incredibly effective procedure, but it can be associated with complications like any medical intervention. The immediate complication from transplant results from low counts following the conditioning regimen. And the symptoms and the side effects are going to be dependent on which count is affected. White counts are low, patients can have infections. When the red blood cell count is low, patients can have symptomatic anemia, and with low platelets can result in bleeding complications. There are other acute and subacute organ toxicities. Very commonly, patients can experience nausea, vomiting, diarrhea, which can be easily treated, but could also develop more serious complications, pulmonary and cardiac issues, and also skin complications with rash, mucositis, edema. Next slide, please. A very unique complication of transplant is the development of a graft versus host disease. Graft versus host disease occurs when the donor immune system attacks the recipient healthy tissues and cells. It's the pathway of this disease is very similar to the graft versus tumor effect. Again, we have T cells from the donor. These are specialized immune cells from the donor that can identify proteins in the surface of cancer cells, but can also get confused sometimes and can identify proteins in the surface of healthy cells. GVHD can be mild, moderate, or severe, and it could be in a small percentage of cases life-threatening. So it's very important to select the best donor for an individual patient and have your patients be compliant with anti-rejection medications to prevent severe GVHD. Very broadly speaking, we have two main categories of GVHD, acute and chronic. Acute occurs in the first 100 days, chronic occurs after 100 days and even years after transplant. And each type can affect different organs and tissues and cause different symptoms. Next slide, please. In graft versus host disease, to the left here, we can see T cells can recognize special proteins in the surface of healthy cells. In the acute presentation, typically affects the skin, the GI tract, and the liver, and patients can present with skin rash, nausea, vomiting, diarrhea, and liver dysfunction. The chronic presentation tend to be less severe, behaves more like an autoimmune disease in which we see chronic inflammation of the skin, eyes, liver, and lungs. And while it's rarely life-threatening, it could really impact the quality of life of the patient, and it could be significant in a percentage of patients. So the best way to treat GVHD is preventing GVHD. Again, optimizing donor options and optimizing anti-rejection medications to avoid this complication. Next slide. As with any transplant, there is a risk of rejection, even if the donor and recipient are fully matched. But graft failure or rejection of the graft is more common when the patients and the donor are not well matched. The most common treatment for failure is to proceed with a second transplant if possible. And while transplant is curative for most hematologic malignancies, some patients with myelodysplasia or bone marrow failure syndromes will experience relapse after transplant. How do we treat that relapse or the disease coming back? It really will depend on a number of factors, including the time of relapse and how the relapse presented. But treatment may include supportive care, chemotherapy, second transplant, or a donor lymphocyte infusion or a stem cell boost. Next slide. Now I want to go into detail about our specifics about transplantations for the diseases we're discussing today. Next slide. In MDS, probably this was discussed, but it's important to understand what are the issues or what is occurring in MDS so we can understand how transplant can help. One of the key problems in MDS is ineffective hematopoiesis. The marrow is not really great at making blood, and that results in transfusion dependence, infections for low white counts, and bleeding from low platelets. So a lot of the treatment strategies are going to be geared towards preventing or treating these complications. MDS also has the ability to transform to more acute forms of disease like AML or ovarian marrow failure. So, and both of these complications are, of course, very severe. It could be fatal. So a lot of the treatment strategies are also going to be directed towards arresting this progression or delaying this progression. We can also result in improved survival. Next slide. So the goals of therapy are really going to depend on the patient and their disease, but could go simply as symptomatic treatment, in which case transfusion, growth factors, and antibiotics can be helpful. When we want to change the natural history of that disease, meaning we want to arrest the progression or delay the progression and improve the patient's survival, we can then use chemotherapy, typically hypomethylators like azacitidine or decitabine, lenalidomide, luspatercept, other chemotherapies, and investigational agents. And if our goal is to cure the disease, then we can offer an allogenic stem cell transplant. Next slide. The treatment of a patient with MDS, or really any patient, it's of course always individualized and depends on the patient's disease severity, age, fitness, and goals of therapy. But in a very general sense, where transplant falls into the treatment algorithm of MDS is typically for patients with higher risk disease. Patients with lower risk MDS, and the definition of lower risk It's slightly different depending on the prognostic tools that we're using. These are patients typically with low blast burden or low IPSS or revised IPSS score. These patients benefit from, again, symptomatic interventions, chemotherapy, and ideally enrollment in a clinical trial. For patients with higher risk disease, if they're young and have a suitable donor, we tend to offer upfront transplantation, typically bridged with chemotherapy or an investigational agent. And while just a few years back, we wouldn't necessarily offer transplant to an older patient, age is becoming less of an absolute contraindication to proceed with transplant. And we have transplanted many patients over the age of 70 if they have a suitable donor, good disease response, and a good performance status. Next slide. The rationale for transplanting patients with MDS, number one, with a transplant, we can eradicate the disease in the recipient's bone marrow with the conditioning chemotherapy, and most importantly, with the donor's immune system. When we suppress the recipient's immune system, we avoid rejection, and we can allow this donor immune system to really function properly and protect the patient from relapsing. And very importantly, too, by providing new healthy stem cells, we can restore normal hematopoiesis with a new graft. The marrow can become efficient at making blood again. Next slide. The indications for transplant, again, higher risk disease with intermediate high or high PSS or revised IPSS. And sometimes we can offer transplant to patients that don't necessarily meet this criteria, but have high risk, they have high-risk features, such as treatment-related disease, refractory cytopenias, patients that fail treatment with hypomethylators or chemotherapy, patients that carry adverse mutations or high-risk mutations that are not necessarily captured by some of these prognostic tools. And sometimes patients with significant fibrosis can also become refractory to therapy and may benefit from transplantation. Next slide. I really enjoy sharing this slide. It's data from the National Marrow Donor Program that shows transplant trends over the past few decades. And what we can see here is that the transplant utilization continues to increase year after year. And this is particularly true for patients with acute leukemias and MDS. But to the right here, and to me this graph is much more exciting, is that not only we transplant more patients every year, but the median age of patients receiving a transplant continues to go up, which is particularly relevant for a disease like MDS, where the median age of diagnosis is 71. It's important that when we increase transplant utilization, we make these transplants safer and more efficient so we can offer to patients that need it the most. The majority of patients, not only with MDS, but with acute leukemias and a lot of diseases that benefit from transplant are patients over the age of 60. So of course, improving outcomes so we can offer transplants in a safe manner to older patients is one of the priorities that we have as a transplant community. Next slide. And while transplant, again, can be curative, not everyone benefits from a transplant upfront. We know that this is particularly true for patients with MDS. On the top panel, you can see these are patients with lower risk disease. And what we can see here, it's the survival is better for patients that do not receive a transplant upfront. This is on the yellow line. We can see here that survival is superior for patients that do not receive a transplant early on if they have low risk disease. But when we look at the bottom curve, we can see that patients with higher risk disease eventually have better survival if they receive a transplant. So the important point here is while transplant is curative, if patients have low risk disease and a good quality of life, we don't necessarily need to jump to transplant right away. But one thing that I tell patients and referring doctors always is, while it's true that not everyone needs an early transplant, and early transplant for some patients can be detrimental, it never hurts to do an early referral. And we encourage our colleagues to refer all patients with MDS to us so we can identify donors early and address pre-transplant issues early on. And then along with the patient, we can make a decision about optimal time for transplantation once the patient is ready. Next slide. This is additional data from a multi-center study 1102, again, showing the benefit of from or early transplantation in high-risk disease. These were 400 patients with a higher risk MDS between the ages of 50 and 75. And the investigators offer them what we call a biologic randomization. That is, if a matched donor is available, they proceed with transplant. If a matched donor was not available, they receive a non-transplant treatment strategy. And we can see here on the blue line that the survival is better for those patients that receive an early transplant strategy. Next slide. Data from the CIBMTR and the National Marrow Donor Program, this is national data from the US, shows that we can have long-term survival in patients receiving a transplant. Outcomes tend to be better in younger patients, but these lines are getting closer and closer as we optimize transplantation of older patients. And the next slide that I also like to show always, next slide, please, shows us that despite the fact that we are transplanted older patients year after year, and that we have expanded our donor pool to use mismatched transplant, which traditionally were associated with worse outcomes, we can see that year after year survival for MDS patients continues to improve after transplant. Back in the 80s, 90s, and early 2000s, less than 40%, and close to 60% now in the most recent series. So very encouraging data and very encouraging to see that for a disease that it's not curative with current treatment strategies, we can offer long-term survival and cure for many of these patients, irrespective of their age, ethnicity, and MDS diagnosis. Next slide. And same information, we can pass the next slide. So we can see again, year after year, survival improves. Now I want to switch gears and discuss transplantation for bone marrow failure syndromes, focusing mostly in aplastic anemia where much of the data is available. Next slide. The issue in aplastic anemia is that, again, we don't have effective hematopoiesis. Patients are transfusion dependent, have infections, have bleeding as a result of very low counts. And this is happening in the setting of a very hypocellular or empty marrow. All these bone marrow failure syndromes also have the potential to transform to acute leukemia, to evolve. And mortality in aplastic anemia typically comes from marrow failure and in some cases transformations to AML. Aplastic anemia has been was historically a fatal disease, and really the outlook and the prognosis of aplastic anemia was really changed with the introduction of immunosuppressive therapy and allogeneic transplantation many decades ago. Next slide. Aplastic anemia is not an isolated disease, and while some patients can present with very distinct clinical pictures, for many patients, the result of bone marrow failure is a combination of clonal evolution or mutations with immune dysregulation. Next slide. The goals of therapy in aplastic anemia are, again, symptomatic treatment, patients with low counts, and we, again, can achieve that with transfusion, growth factors, antibiotic, iron chelation, impact the natural history. And we can do that with immunosuppressive therapy, cyclosporine, ATG, eltrombopag, investigational agents, and curative treatment that we can offer with an allogenic bone marrow transplant. Next slide. For most adults, if they are under the age of 40 and they have an HLA matched sibling, we typically offer allogenic transplant upfront if they have severe disease. For all other patients, we offer immunosuppressive therapy plus eltrombopag, and we reserve transplantation as a second-line therapy or third-line therapy depending on the patient's fitness, disease status, and availability of a suitable donor. Next slide. And while immunosuppressive therapy, again, has really revolutionized the way we treat aplastic anemia, really changed the outlook and the prognosis of patients with aplastic anemia, not every patient responds to IST. And for those who do not respond to immunosuppressive therapy, survival can be very poor. And in this particular population of patients, salvage with an allogenic transplant is also an attractive option and a very effective treatment strategy. Next slide. The indications for transplant in aplastic anemia are most of these bone marrow failure syndromes, severe disease with an ANC of less than 500 or 200, hypocellular marrow, young age. And young age, again, it's a moving target. Many years ago, we considered young age less than 30 for transplant purposes. That number moved to 40. That eventually we are transplanting patients under the age of 50, and some select patients even older. But again, for most patients, the cutoff it's 40 and 50, and availability of a suitable donor. And that is another factor that remains a moving target. For aplastic anemia, we continue to aim for a fully matched donor, ideally a sibling, but the role of alternative donors, haploidentical transplant, mismatch transplantation, it's clearly emerging and evolving in the management of aplastic anemia. Next slide. The rationale for transplantation in aplastic anemia is to suppress the recipient's immune system, to prevent additional marrow injury, rejection, and allow this new immune system to function properly. And importantly, also restore normal hematopoiesis with a new graft. Again, allowing the marrow to function again with healthy stem cells. Next slide. I want to share with you a story of serendipity, survival, and really being at the right place at the right time. I learned the story of Nancy Laurie actually just a couple of months ago before I volunteered to participate in this activity, and it was pretty inspiring. Nancy Laurie received the world's first successful bone marrow transplant back in 1960. When she was 6 years old, she was diagnosed with aplastic anemia. She lived in Seattle with her family and had an identical twin sister. Nancy was seen at the University of Washington Hospital, and like most patients with aplastic anemia at the time, was offered supportive care and sent home on hospice care. Luckily for Nancy, the intern that was assigned to her care knew about a very famous hematologist that was in town lecturing some of the doctors in the hospital where Nancy was being treated. This doctor was Dr. Donald Thomas. Dr. Donald Thomas had performed identical sibling transplantations in kids with acute leukemia without no long-term survivals at the time that Nancy was treated. But the team at the University of Washington convinced Dr. Thomas to try this strategy on Nancy. They collected stem cells from her identical sister, and Nancy received their first successful allogeneic bone marrow transplant back in 1960, and remains alive and healthy to this day. Next slide. And while a lot of things have changed in transplant since Nancy got that transplant from her sister, the gold standard for transplantation in aplastic anemia remains the same. We continue to aim for an HLA identical sibling, and the best outcomes continue to be reported in patients that receive a match from an identical sibling. Survival in most recent series is close to 90%, much better for younger patients, less than the age of 40. But again, we can have long-term survival in patients over the age of 40. Next slide. For patients that do not have a matched sibling donor, we have also data to support that unrelated donor transplantation, these are donors from the registry that are fully matched with the recipient, can also result in very encouraging and promising survival, also reaching 80 to 90% survival long-term in most series. Next slide. And again, unrelated transplant outcomes are best in younger patients, close to 70-80% in patients under the age of 40. Most recent series show better survival, which we expect with better technology for HLA tapping and supportive care for graft versus host disease. Next slide. This is data from the National Marrow Donor Program, also showing that survival for patients with aplastic anemia, again, very promising, continues to be best for patients that receive an HLA matched sibling donor and those who are younger. And next slide. And what I thing is also important to share is even for patients that do not have a matched sibling donor or a matched unrelated donor in the registry, the use of haploidentical transplant is emerging as a very promising treatment strategy. Again, haploidentical transplant are half matches. We are haploidentical with our parents, we are haploidentical with our kids, and there's a chance that we will be haploidentical with some of our siblings. This is a small study by Dr. DeCern and colleagues, and they evaluated haploidentical transplantation in almost 40 patients with aplastic anemia. Most of these patients had refractory disease to immunosuppressive therapy, and as we can see here, the long-term survival was close to 100% many years out from the transplant. So while not considered a standard of care, it is certainly a very attractive strategy. It's considered a standard of care in some countries. China does offers upfront transplantation with haploidentical transplant for most pediatric patients. But again, very promising outcomes and certainly a treatment alternative for patients who do not have a fully matched donor in their family or in the registry. Next slide. Again, survivals are better for pediatric patients. This is also data from the National Marrow Donor Program, and we can move to the next slide. Mirroring the data from MDS, we can see here again very encouragingly that year after year, outcomes for long-term survival following transplantation in aplastic anemia continue to improve. Survival close to the 40s, back in the 80s, 90s, and early 2000s. And again, most recent series report survival in the 80 and 90% range. Best survival for young patients, best survival for the recipients of fully matched graft. Next slide. So transplantation for aplastic anemia, it's very effective and can be curative. It's important to mention that immunosuppressive therapy can also be very effective. Long-term survival close to 90%. We continue to have some challenges for patients who cannot identify a suitable donor, and there is room for improvement in outcomes for older patients, given higher rates of graft versus host disease and non-relapse mortality. Next slide. I briefly want to talk about also PNH. While there's not too much transplant data for patients with PNH, there are clear indications for transplant, and there are long-term survivors and can be offered to a number of patients with PNH. The introduction of eculizumab and some of the complement-guided therapies or targeting therapies has also revolutionized the way we treat PNH. And for patients with classic PNH, with a high PNH clone, treatment with eculizumab or some of the complement inhibitors, it's obviously the first choice. But there is room for transplantation in patients with refractory therapy and those who present with PNH that is happening in the setting of a concurrent underlying malignancy, such as MDS or aplastic anemia. These patients are also very likely to benefit from transplant if a suitable donor is identified. Next slide. The indications for allogeneic transplant in PNH include refractory bone marrow failure, clonal evolution. Patients can also progress to a more acute myeloid disorders. For those patients that fail to respond to eculizumab or complement therapy, we can also offer a transplant. Next slide. And we know that while data is not abundant, there is it's an effective treatment, and we have long-term survival in patients with PNH receiving allogeneic transplant. This is data from the European Bone Marrow Transplant Registry. Important to mention this is retrospective data prior to the eculizumab era. And even back then, most patients were able to achieve long-term survival. Best responses were seen in patients that received transplant for refractory hemolytic anemia. And most recent data showed pretty promising survival with a matched transplant with survival close to 88 at 3 years. This was recently published a few years ago. So it's not our leading indication for transplant, but certain patients meet criteria for transplantation and can be safely and effectively transplanted if needed. Next slide. So I want to go over some of the take-home points. Transplantation continues to be the only treatment with curative potential for patients with MDS and for most patients with bone marrow failure syndromes. Age alone should not be a contraindication for transplant evaluation, and more performance status and overall health should be the main drivers for transplant eligibility. It's never a mistake to refer too early. So early referral to a transplant center can help us identify donors early on and ensure that we can address pre-transplant issues in a timely manner. For MDS, higher risk disease can benefit from upfront transplantation. Next slide. For patients with bone marrow failure and aplastic anemia, they fare better with a bone marrow graft, and they fare better with a matched donor and a young donor. Utilization of transplant in PNH has decreased in the era of eculizumab, but continues to be an option for patients with refractory disease and for those patients that are not able to receive therapy with an anti-complement complement inhibitor. As with any treatment, careful consideration of the pros and cons is important before deciding on proceeding with transplant. And the best treatment for all patients is enrollment in a properly conducted clinical trial involving transplant or not. With that, next slide. I want to thank you all for your attention, and I think we have ample times for questions. I'll be happy to take any questions you have. Thank you very much.
Thank you so much, Dr. Jimenez Jimenez. We do have several questions. We'll start with a question online. The first question is, how can a patient select the hospital that would be best for them to receive a bone marrow transplant?
That is a very good question. I think it really will depend, obviously where the patient is located. There are many resources that patients can use. What I would recommend to that individual patient, have a conversation with their hematologist to discuss which transplant hospital they are familiar with and working. If they're not able to obtain this information from their primary hematologist, organizations such as the National Marrow Donor Program, Be the Match, and the CIBMTR also can, and BAMT Infonet can also connect patients with transplant providers in their area, or patients with providers that are specialized in the disease that patient has. And I'll be happy after the talk to share some of those links if patients need it.
Thank you so much. Do we have any questions in the room? Did you have a question? Hold on 1 minute and I'll bring the microphone to you. Here we go.
Doctor?
Mm-hmm.
I'm old. I'm really old. But you mentioned that risk versus reward. But
correct.
You're the one that decides risk versus reward. Because you're going to eliminate me because I'm too old. So if I have a 50-50 chance of surviving taking a transplant versus having 3 more months to live, why couldn't that be my choice? That's my question.
Yeah, that's a very good question. I tell you what I tell most of my patients. These are never decisions that we make alone. I tell the patient, I tell every patient I see that the decision to proceed with transplant is a decision that we make in tandem. Okay, I don't know specifics about your case, but I can tell you there are situations in which, and this is true for younger patients. We need to do a very comprehensive assessment of the patient's disease status, comorbid conditions, and again, availability of suitable donors. We can't really, we don't have a crystal ball to know how a particular patient is going to fare, but we have prognostic tools that are fairly accurate to give us an idea of what their transplant is going to look like. If we believe that we can benefit the patient with a transplant, or we do it with a very excessive mortality, then that patient will more likely to benefit from other treatments. But I can tell you, age in on itself it's really not an absolute contraindication. I have transplanted patients with mismatched transplant over the age of 75, which is something that we wouldn't dream of doing many years ago. And on the same token, I have told patients in their 50s and 40s sometimes that we can proceed with a transplant because we won't believe it will be beneficial. So I will say age alone in on itself, it's not an absolute contraindication. We have offered cell therapies to even patients, not necessarily an allogeneic transplant, but other cell therapies to patients in their 80s and 90s, and again, I can tell you, I have personally a patient I saw recently. He's 3 years out from the transplant. He's 79 now. He received a mismatch transplant at age 76. So I think comorbid conditions and performance status rather than age alone should be the real drivers of determining fitness for transplant.
Okay. I'm 79. And
That in on itself might not
I
necessarily
have
be an
all
exclusion,
the
but again, we have to look at the whole
medical-
picture, right?
Pardon? Anyway.
Again, no. What I'm saying is 79 alone is not necessarily a full exclusion, but we have to look at the whole picture.
Okay.
In a patient over the age of 70, we tend to be a little bit more strict about organ function and disease response and donor options being optimized.
Okay. Thank you.
You're very welcome.
Okay. Any other questions from in the room right now? If not, we'll go to one that's online. Our next question is, what is the difference between a stem cell transplant versus a bone marrow transplant? Are these terms essentially interchangeable?
That's a very good question. And it can get a little confusing. So they can be interchangeable. So a bone marrow transplant, was a term that we used many years ago because most of the transplantations were done directly by removing stem cells from the bone marrow. So all of these transplants are considered hematopoietic cell transplant or stem cell transplant, okay? And there are different modalities of transplant. We can do a transplant harvesting cells directly from the marrow, and we will call that kind of transplant bone marrow transplant, okay? This is a transplant modality that is very favored in diseases like aplastic anemia or bone marrow failure syndromes because the number of T cells on the graft is lower, okay? And we have less likelihood of GVHD, graft versus host disease. A stem cell transplant, it's all, when we don't use the bone marrow, we can collect stem cells from the peripheral blood, and we call that a peripheral blood or a mobilized stem cell transplant. Okay, so these are kind of like, and the third type of graft is using cells from a cord blood from a baby. This transplant we offer mostly to pediatric patients. So bone marrow, cord blood, and mobilized peripheral blood are all different kinds of stem cell transplant. Does that answer the question?
Yes. Our next question is, and this comes from a patient diagnosed with very severe aplastic anemia that has no full match for a transplant. What lab values would lead you to recommend a transplant?
More than a single value alone, I will say, well, we look at disease severity. So we're looking at the ANC, we're looking at the bone marrow cellularity, we're looking at the patient's transfusion dependence, and then we also evaluate what the donor options are. We continue to favor fully matched donors because the data appears to support that best outcomes are seen in the setting of a well-matched donor, whether that's a sibling or not. But again, for patients that do not have other therapeutic options, we can consider mismatched transplantations with, say, a haploidentical transplant in certain situations. So if this is a patient that requires an evaluation, I think that's something important to discuss with the patient. Ideally, these mismatched transplants should be offered in the context of a clinical trial, but many centers, including Sylvester, have expertise in mismatched transplantation, and we will be happy to see him in our clinic and evaluate him. If we believe that he could benefit from transplant, we could certainly arrange for that.
Thank you. Our next question is, would a repeat IST be better than a half-match transplant for a patient who has refractory aplastic anemia who is barely transfusion independent?
It's a tough question. We don't have a randomized trial to tell us which strategy is better. It will also depend how long the response was the first time around, and it's sometimes important to get a little bit more information about the specifics of the disease. If we have a patient that is in good shape, they're young and they have a haploidentical donor that we can transplant safely. And there are, of course, many things that we have to look at: the presence of donor-specific antibodies, make sure that the patient's organ function is adequate. We tend to offer a transplantation with failure of immunosuppressive therapy. But I don't think it will be erroneous to consider a second line of immunosuppressive therapy, especially if enough time has elapsed, if they achieve a good response the first time around and that response was just eventually lost, and or if the patients do not have a good transplant donor options, including not even suitable haploidentical options. Sometimes, even though we potentially could all have haploidentical donors, that's not the case for some patients, or their haploidentical donors, whether that's their siblings or parents, might be too old or frail to donate. So, but again, I don't think there's an absolute. We tend to favor transplantation after failure of immunosuppressive therapy if we can perform the transplant safely.
Thank you. If after a transplant, blood counts don't return to normal but remain consistent, is this normal?
Yes and no. It takes, depending on the patient's age, the number of cells we infuse, the conditioning regimen, and the type of transplant we do. It can take sometimes months for the bone marrow to fully recover. And for some patients, I have patients that could be many months out, and their hemoglobin is still in the 8s and 9s, and the platelets are still on the 30s and 40s. Especially, we see this in patients that receive reduced intensity conditioning, where it takes some time for the donor's immune system to fully take on. Okay, but for most patients that are transplanted with good disease response, even though it might take months and sometimes years for counts to fully go back to quote unquote normal, most patients are able to achieve transfusion independence. If that doesn't happen after a few months, it's important to evaluate if there are any other reasons why this is not happening. Is the graft failing? The body rejecting the transplant? Are we being too aggressive with the anti-rejection medication? Is there a concurrent infection that is causing the counts to drop? So, obviously, depending on the time, it might be normal. In certain situations, we have to investigate more so we can offer treatment if the patient is experiencing graft failure.
Thank you. Our next question is, do haploid transplants require more intensive chemo? They're asking because they're curious if female fertility after a haploid transplant, if a female patient would be able to conceive and carry after a haploid transplant.
Yep, that's a very good question. A haploidentical transplant, we can offer high-dose chemotherapy, or we can use reduced-intensity chemotherapy. But even for reduced intensity chemotherapy, by definition, all transplants require high doses of chemotherapy. Otherwise, the transplant will not be efficient. So we will always recommend, even before a non-myeloablative or a reduced intensity conditioning, that the patient undergoes a comprehensive evaluation with a fertility specialist so they can discuss their option, including banking eggs, in vitro preservation. That's, of course, that's something that they have to discuss with the fertility specialist according to their goals or what they want to do. But yes, certainly, even for patients receiving a non-myeloablative for reduced intensity, if they are of fertile age and they have a desire to have kids later on, we always recommend a fertility evaluation before transplant. So these options can be discussed.
Thank you. This question is regarding the donor. What is the process like for the donor? Are they out to sleep, or is it just like donating blood?
It depends on the type of transplant we do. If we use a peripheral blood graft, that is the patient, the donor, it gets mobilized, and then we collect the cells from the peripheral blood through a special machine. They don't have to be out. This is an outpatient procedure. That said, this is a procedure that takes some time. We typically require 10 to 14-day commitment from the donor to complete all the pre-transplant testing and everything that needs to be done. For patients that donate bone marrow transplant, and this is particularly relevant for patients that are donating for a patient with aplastic anemia, where we favor a bone marrow graft, Yes, this is a procedure that needs to occur in the operating room and involves general anesthesia.
Thank you. What is the most common form of graft versus host disease?
The most common form of graft versus host disease that what we typically see, skin is the most common presentation, acute skin.
Thank you. This question is from a patient who has MDS and they had a
Mm-hmm.
transplant. They're 3 years out of transplant. However, it looks like their transplant is failing. Can a person have a second transplant? Should you use the same donor or search for a new donor?
Yes. The short answer to the question is yes, they can have a second transplant. I have had patients that have received even like a third transplant. It's not common, but it can be done. Um, the optimal treatment of post-transplant relapse, which is what it seems like what that patient is describing, again, depends, and I touched on that on one slide. It really depends on how quickly the disease is progressing. And it seems like this was 3 years ago. The good news seems like, not knowing all the specifics, if patients that relapse after 2 years are more likely to respond to subsequent therapies, we can offer a second transplant. There was actually a study specifically looking at this question: will a second donor will be better, like different donor will be better? And there's really no, the study didn't show that a different donor was particularly better. There are situations in which we will probably prefer a different donor, and that will be based on specific testing that tell us, it's called a chimerism study. How many did the relapse happen when all the donor cells were there? Were they all cells trying to come back? One of the other strategies in a patient with MDS, and I don't know this patient's age, but considering if they didn't have a lot of disease on the marrow and they were relapsing years after the initial transplant, one of the treatments that can be used is a donor lymphocyte infusion, in which we take T cells from that original donor and we can infuse them to strengthen the original donor's immune system in an effort to eradicate disease. The data that we have comparing this donor lymphocyte infusion to a second transplant seems to show that both strategies are comparable, and survival is not necessarily better with one or the other. Again, I don't know all the specifics about this case, but to answer the question, yes, a second transplant can be done. We don't have data that suggests that a different donor is necessarily better, but every case is different. And three, I think there will be an important option to discuss will be if a donor lymphocyte infusion, which is a much less invasive procedure, is an option for him or her.
Thank you. The next question is, my family is in the process of being tested to see if they can be my donor. They've been told to
Mm-hmm.
do not donate blood. Why?
That they can donate blood.
They've been told not to donate blood.
Well, what we typically tell patients, we don't donate blood. They're asking, probably, I'm assuming they're not, don't donate blood for them. They can donate blood elsewhere. They shouldn't be donating blood for that intended recipient. That could increase the rate of complications after transplant.
Oh, okay. Thank you. For graft versus host disease, how long after transplant would a patient expect or not expect to be free of graft versus host disease concerns?
Yeah. For acute GVHD, we have arbitrarily chosen 100 days, but in reality, medicine doesn't really work like that. Most patients with acute GVHD typically present with GVHD the first 100 days, but we can see it, I will say, for the first year. Chronic GVHD, it's can present years after transplant. So, and that's why it's important for patients that that receive an allogeneic transplant to continue to follow their doctors for many years after transplantation. What I tell most of my patients, and again, this is not a rule, but for most diseases and most patients, the likelihood of relapse 2 years after the transplant is very low. But I continue to tell patients that even after 2 years, they still need to receive medical attention, because we have to watch for other things, including chronic GVHD. I will say it's likely that someone that never experienced GVHD is going to experience a bout of chronic GVHD 10 years after, I will say exceedingly unlikely. But for someone that experienced some degree of GVHD, chronic GVHD can manifest years after. That doesn't mean that the patient needs to be in the clinic every week. It means that they need to continue regular follow-up with their transplant doctor years after their transplant. The likelihood of severe life-threatening GVHD years after transplant is low, though.
Thank you. Is there a point in time where a patient no longer needs to be concerned about developing graft versus host disease?
For chronic GVHD, I would say we don't have a specific time point. Some of the testing that we do to assess for chronic GVHD, if the patient has no evidence, we tend to stop after 5 years. But that again, this is an arbitrary number. I will say if a patient has not experienced any GVHD 5-10 years after transplant, it's exceedingly unlikely that they ever will. Again, because we don't know when this could happen, and some of these manifestations cannot be immediately symptomatic, we continue to follow our patients years after the transplant.
Thank you so much, Dr. Jimenez, for sharing your time and your expertise with all of us today. If you'd like to watch this session again at a later time, it will be available on the conference platform within the next hour by accessing the session, clicking on replay, or by navigating the on-demand tab in the platform hub. If you have any additional questions, please feel free to send it to us at any time in 3 ways. Send an email to help@aamds.org, call our helpline at 800-747-2820, or submit your question to our Facebook page. If you're watching online, please take a few moments to fill out the session survey. Your input is important to us and helps us plan for our future programming. This does conclude the educational sessions of the conference. However, we hope that you will join us at 2:15 for the online support groups. You will find the Zoom link on the platform to be able to join. On behalf of the Aplastic Anemia and MDS International Foundation, I'd like to thank you for joining us today and making us your resource of choice for information on bone marrow failure diseases. Our medical advisory board and team are always here to support you and your family for the past 39 years. This concludes the conference and our session. Thank you again.
Thank you very much. Have a nice day.